All right, good evening, everyone. Thank you all for joining United Spinal Association Greater Philadelphia Chapter Monthly Educational Webinar Series. We are very excited to have Stephanie Bennett here with us tonight to talk about upper extremity impairment and spinal cord injury. Stephanie Bennett is an occupational therapist and research coordinator for the Center for Outcomes and Measurement at Jefferson College of Rehabilitation Sciences at Thomas Jefferson University in Philadelphia, Pennsylvania. Her research focuses on outcome measurement development and validation, pediatric brain injury, and spinal cord injury. So we're very happy to have Stephanie here with us tonight. Please use the chat feature for any questions that might come up during the webinar, and we will answer those at the end. Or if you would like, at the end of the webinar, I can take you off mute if you would like to talk with Stephanie regarding any questions. At the end of our webinar, please be sure to view our chat box, as you will find the link to our YouTube channel, where you will be able to find this and all of our other recorded webinar videos. And also pay attention for the Greater Philadelphia chapter link to join if you are not a member of United Spinal Greater Philadelphia chapter. Now I would like to welcome and introduce Stephanie Bennett.
Thanks, Megan. I really appreciate it. And thank you guys all for coming today. I really appreciate that as well. So I'm going to go ahead and share my screen so I can show you guys the PowerPoint that I have created for the webinar today. Okay. I'm going to keep it just on this view, just so it's a little easier to go through the PowerPoint slides. And then, like Megan said, if you guys have any questions at all, feel free to put them in the chat and I'll be happy to address any of your questions at the end of the presentation. So a little bit of the objectives for our presentation today. We're going to be talking about the cause of upper extremity injury post spinal cord injury, learning about which areas of the body are susceptible to injury secondary to spinal cord injury specific mobility and wheelchair use, and understand and learn of different exercises to assist with pain and prevent injuries to shoulders and wrists. So a little bit about the background. So manual wheelchair propulsion. So manual wheelchairs, as I'm sure many of you guys are aware and probably use on a daily basis, those are the ones that we have to push with our hands, right? So some of them do have like a drive assist, or where you push and it kind of like helps you propel a little bit. Most of them are lightweight now, and depending on like the purpose of the manual wheelchair, they may have different types of customizations so that they're a little bit easier to access for day-to-day use. However, wheelchair-related daily activities do cause a very heavy load on upper extremities. So in comparison to people that are ambulatory, we primarily use our legs and our arms don't do a ton for helping our mobilization, right? When you have to use your wheelchair every single day, you're constantly in this like position where your arms are back and you're propelling forward, which puts a lot of stress on your shoulder joints. So a lot of times we do see people with spinal cord injuries that have pain or limited mobility in their shoulder specifically. And then anything that happens to the shoulders tends to kind of trickle down and also affect the elbows and then also affect the wrist and your fingers as well. We see this especially in people with a cervical spine injury. So a cervical spine is going to be your neck. So if you had an injury anywhere in your cervical spine, a lot of times you'll see either it's called impingement, where you have some issues within your shoulder joint capsule. And because of the weakness associated with that injury in like your biceps, your triceps, and even some of those wrist muscles, you'll see increased pain and possible range of motion deficits in those shoulders, which is also further impacted by that manual wheelchair propulsion. We also tend to see higher muscle strength and higher functional outcomes, which correspond to fewer complaints of pain. So a lot of times going into prior receiving a spinal cord injury, if you are a human that has pretty good muscle strength, you tend to see it be a little easier to complete those daily tasks that one would need to complete as a person with a spinal cord injury. So whether that's transferring in and out of your chair, or getting dressed or propelling that chair, the stronger those muscles are in your arms and your shoulders, wrists, fingers, you tend to see fewer complaints of pain. So a lot of times we recommend for any human, especially for people with spinal cord injuries, you don't want to overtrain those muscles, because then you can have pain from working out too much, but you want to try to maintain that strength and just keep an overall healthy, strong physique, because that can decrease your pain, and it's going to decrease the load that we put on our shoulders with all of those tasks that we have to do day to day. For the purpose of this PowerPoint, we're going to refer to tetraplegia as people that have all four limbs impacted. As of recently, within the last couple of years, they've started to move away from quadriplegia as a term to describe people with spinal cord injury, excuse me. It tends to either be tetraplegia or paraplegia. So people that have tetraplegia, where it's either 3 or 4 limbs that are impacted from the spinal cord injury, it doesn't necessarily have to be a complete spinal cord injury. You can still be incomplete and a tetraplegic, but you tend to see these people report more upper extremity musculoskeletal pain. And they also report increased pain in not only the shoulders, but also in their hands, wrists, and elbows. The most frequent pain that is reported between tetraplegics and paraplegics is often the left and the right shoulders, which again is often because of that high load that we have to use to transfer in and out of wheelchairs, to propel wheelchairs, and you rely substantially more on your arms to complete almost all of your daily living tasks. So whether that's getting dressed, getting showered, cooking your meals, all of those things tend to rely so much more heavily on the arms that you almost burn out those joints from the overuse of completing all of these activities that we have to complete every day. Pain tends to be mild to moderate, according to all of the studies that we have done research on, and the literature tells us that pain tends to be mild to moderate, and most people experience pain 3 or more times per week. So what that tells me as an occupational therapist and as a researcher is that pain can significantly decrease your quality of life, right? If you're in pain every single day, then what is the benefit or the motivation to wanting to get up and continuing to do things every day? So what we need to focus on as a rehab profession and as a researcher is how can we decrease that pain so that people with spinal cord injuries can continue to live their life to the fullest and to engage in the things that bring them joy every single day. Doing that while in constant pain is very challenging, to say the least. So we're going to talk a little bit about the level of the spinal cord injury and the associated pain with that level. So muscle strength is typically assessed through what we call manual muscle testing. So if you have ever had occupational therapy or physical therapy, they will often say, like, can you reach your hands all the way to the ceiling? Can you touch the back of your head? Are you able to bend your elbow, straighten your elbow? And they'll apply a little bit of resistance to kind of get a grade on how strong your muscles are. Functional independence measure is an assessment of your ADLs. So your ADLs are going to be those daily living skills. So those are going to be getting dressed, getting showered, getting from point A to point B, because if you can't get into the bathroom or get into the kitchen, then it's going to be a little harder to complete that cooking or showering or brushing your teeth or whatever it may be. So looking at a manual muscle test and a functional independence measure, they give us different kinds of scores. So these are assessments that we tend to use in a hospital setting or even an outpatient setting. And they give us a little bit of feedback and information on like how well your muscles are moving. How much assistance do you need to complete those daily activities, to get dressed, to shower, to brush your teeth? When we look at these scores, they tend to tell us all of that information, right? So the higher your manual muscle score, that tells me that you are pretty strong. So the highest score that you can get on a muscle is a 5. So if you have 5s for strength in all of your different joints and your shoulders and your biceps and your triceps, And then you also have very high FIM scores. So that would be that you can independently brush your teeth, you can independently get dressed, you can independently push your wheelchair. The higher your independence and the higher your strength, we tend to see 10 to 15% fewer shoulder pain complaints, which kind of goes back to the previous slide, which was saying how the stronger your muscles are, the more you tend to have a decrease in pain because your muscles are able to sustain the load that you have to ask them to do on a daily basis. Also, we want to take a look at BMI. So BMI is body mass index. So what that looks at is your height in comparison to your weight. So the higher the BMI, so that is genuinely associated with obesity, overweight, or you tend to weigh a little bit more than you should. The higher your BMI, so the more that you weigh, the more challenging your transfers and the higher the drag force is during your wheelchair propulsion. So if you think about super fast cars, right, like Ferrari or Lamborghini, those are very small and aerodynamic. So it's easier for them to go faster because there isn't a lot of drag from the air pulling on that car to slow them down. Very similar with your body. So the smaller your body is, the more muscle strength that you have and the less fat that you have on your body, the easier it's going to be to transfer. One, because your muscles are so much stronger that it's easier for you to propel your body from one point to another, right? And in transfers, we're kind of thinking about like those popover transfers, a transfer board transfer, the transfers where you're using your head and your hip ratio to kind of lean one way and pop the other direction. So the higher your BMI is, so the more that you weigh, the harder it's going to be for you to get your body from one position to another. And the more that that drag force, so the air that you're trying to push yourself through, is going to negatively impact not only your wheelchair propulsion, but also your body's ability to move from point A to point B. So that does make a pretty big difference in your wheelchair propulsion and just your general mobility. We also want to talk briefly just about early onset of pain. So the earlier that you start to experience pain, that is the most important predictor of pain presenting at a later stage in rehabilitation. So what this is referring to is shortly after your spinal cord injury, when you're in an acute rehab setting, right? So you're getting therapy every day for 3 hours a day. If you're having pain in that setting, in those exercises, and I'm talking about like not just muscle soreness, like true pain in your shoulders and your wrists and your elbows. If you're having pain in those types of settings with those types of movements, it's highly probable that you are going to experience pain later on in rehabilitation. So you don't want to work through the pain. You definitely want to let your therapist or your doctor or your whoever's following you at that moment in time. And even if you're still experiencing pain now, you may want to reach out to your doctor. So I tend to recommend people to reach out to their PM&R doctor. So that is your physical medicine and rehabilitative doctor. Or you can even reach out and get a pain consultation. Some of that pain could be kind of residual pain from issues that were never fixed in the beginning of your rehabilitation. Because as humans, we use our arms and our bodies for everything throughout the day, right? So if you had a shoulder injury prior to your spinal cord injury, it's very feasible that some of those residual effects from the pain of the original injury pre-spinal cord injury are continuing to impact your ability to engage in those dressing, transfers, wheelchair propulsion, all of the above. So make sure that we're paying attention to that early onset of pain because we want to try to problem solve and eliminate as much pain as possible as soon as possible so that it doesn't turn into something more chronic. Okay, so what causes pain in the shoulders for people with spinal cord injury? So we've talked a little bit about like strength and how increased strength can make us have less pain. We've talked a little bit about the more that we weigh can also cause us to have more pain. So are there other things that cause pain in shoulders for people with spinal cord injuries? So there are. A lot of the cause of shoulder problems in spinal cord injury are often due to muscle imbalance, postural changes, and chronic overuse and repetitive trauma. So trauma in this slide in particular, what we're referring to, isn't necessarily like true trauma in the sense of like you fell out of your chair and you sustained trauma to your shoulder. Chronic overuse can cause repetitive trauma. So if you think about people that play golf, like professional golfers or professional baseball players, they tend to get something that's called tennis elbow, or like golfer's elbow from just constantly using those same muscles over and over and over again. Those muscles never have a chance to relax and kind of go back to their original size. So what happens when you're strengthening your muscles is you're actually tearing all of the muscle tendons and like the muscle fibers and all of those things that make up your muscles, and then they have to heal themselves, and then you would work out again. Unfortunately, as people with spinal cord injuries, you don't have the luxury of not using those muscles over and over again, because those muscles, especially those ones in our shoulders and biceps, triceps, wrists, are the ones that help us get from point A to point B, that you have to rely on to do those daily activities, right? So because of that chronic overuse, and it is also considered repetitive trauma because we're using those same muscles over and over again, and they never are able to get a break. So that also can lead to muscle imbalance. So when we go to the gym, right, we're going to have leg day, we're going to have arm day, we're going to have back day, we're going to have all of these different muscles so that we can break down each day, look at one particular muscle group, and then the next day, let that muscle group rest and work on something else, right? Muscle imbalance often occurs when we are working out the same muscles over and over and over again, which we just talked about is very hard to avoid as a person with a spinal cord injury, because we have to use those muscles to complete those daily activities without giving them a break. So what we tend to see is that the muscles that you use for wheelchair propulsion, so that's going to be your trap muscles, these ones up here, your deltoids, so your shoulder muscles here, your biceps and your triceps, and even your back muscles from bringing your arms back and pushing forward. Those muscles tend to get strong very quickly. But then we tend to almost neglect some of those other muscles that help to balance out the muscles that we're using every single day. So that muscle imbalance can actually cause other things to kind of pull out of alignment and cause pain because of the muscle imbalance. So as much as possible, we want to make sure that we're training full body in every capacity that we can. So if we're not ambulatory, that doesn't mean that we can't work on our leg muscles. We can still get in a standing frame. We can still do massage, do range of motion, do kind of some of those things to maintain the integrity of the muscle that we have in that area. We also see some postural changes. So because of that position for pushing the wheelchair, we tend to see our shoulder muscles get tightened and short. That's because as your muscle gets stronger, it tends to almost like tighten up because it's constantly in a state of being used. And so when you activate your muscle, like if you were to squeeze your bicep, you're going to feel that it gets tight because you're feeling the strength there, right? Well, when it gets tight, everything pulls together and it shortens as well. So that shortening and that tightness is good for short term to complete the activity that you're trying to complete. But long term, what you tend to see is that it's very hard to straighten your elbow because your bicep is getting all of the strengthening and your tricep isn't getting as much. That tightening and shortening can cause constant bend at your elbow, even slight bend. It can also cause your shoulders to pull into this more rounded position. The more rounded your shoulders are, the less space there is in this area. And a lot of things travel through this area from our spine. So this holds your brachial plexus, which actually controls the entirety of your upper extremity. So we want to make sure as much as possible to try and keep our shoulders back and our chest out and our neck elongated to try and give as much space as possible for all of those nerves and tendons and muscles to travel in this area. Because what happens is that this curving of the spine and the curving of your shoulders and your shoulders being in your ears is called kyphosis. So that is a curving of your spine, which is not natural in comparison to the way that your spine naturally curves. So your spine naturally curves more like a C than the opposite direction, which allows space for all of these nerves and tendons and muscles to travel and to get blood flow and communication from your brain as optimally as possible. The other thing is that the etiology of the pain, so where the pain comes from, is often associated with high joint forces. So that means that you are using a lot of strength and a lot of speed to complete different movements, which requires a lot more muscle recruitment. So when do people with spinal cord injuries tend to experience these high joint forces? You're going to see them with those pressure releases. So when you're pushing yourself up, you tend to do it kind of quickly because the momentum helps, right? Similarly with those transfers, because you have to use the momentum of the head-hip ratio to get yourself into a better position in your chair. Ramp propulsion is also a big one. So you really have to get going to get up those ramps, right? You can even think about the streets of Philadelphia, how they are not even at all. And so even though there may not be a ramp per se, because of the constant changes in elevation, it requires a lot more strength and quick movements to get from point A to point B. We also see some of these high joint forces in the initiation of your wheelchair propulsion. So once you start propelling, it's a little easier to keep going, but that initial push requires a lot more strength and contraction of those muscles, which can in turn result in pain. So when the joint force increases, we see an increase in the trauma to the area. So again, trauma doesn't necessarily mean like falling and hitting that area. It just means that you are asking your muscle to do a lot in a very quick amount of time, and you're doing it over and over and over again, which can lead to pain because of the overuse in these joints. So your shoulder joint, your elbow joint, your fingers, your wrists. So why does wheelchair propulsion cause shoulder pain? So it's the repetitive nature of the stroke pattern involved in the wheelchair propulsion. So if you can see here in this image, we constantly have a little bend in our elbow so that we can propel the wheelchair, right? You can also see that despite this wheelchair seemingly to fit this person pretty well, right? So what we're looking at for the wheelchair to fit the person pretty well is that 90, 90, 90. So we're looking at 90 degrees in our hips here, 90 degrees at our knees here, and then also 90 degrees in our ankles here. So her ankle angle is a little off, but that's okay because we're more concerned with the knee and the hip. So the more that you're in a better position in your wheelchair, the easier it's going to be for you to propel it. However, that's not going to completely remove that repetitive nature of your stroke pattern, right? So what about the stroke pattern causes shoulder pain? So stroke pattern, which is the propulsion, that the position you have to put your arms in to propel your wheelchair, encourages protraction, elevation, and internal rotation of your arm. So those are very large words, right? What does protraction mean? So if you look at your scapula, which is your shoulder blade is on your back, right? So what happens is that protraction is kind of like when you round your shoulders like this, as opposed to retraction, which is pulling your shoulders back, like there's a pencil in between your shoulder blades that you're trying to squeeze and you don't want it to hit the floor. So the stroke pattern of your wheelchair, even if you just do this sitting in your chair right now, freeze at the front. See how your shoulders are automatically coming into that rounded position. It's very hard to avoid because of the stroke pattern that is required to propel that wheelchair, right? But that protraction can cause impingement in this area. And also because of the repetitive nature, again, we're seeing that chronic overuse of these muscles, right? Elevation is when your shoulders are in your ears, which a lot of times we see because it allows you to recruit more muscles here to make the propelling a little easier if your biceps and your triceps aren't strong enough, or your grip isn't strong enough. You recruit all of these muscles to make it a little easier, but in turn, you're kind of getting stuck in this position, which can cause shoulder pain. And then internal rotation. So if we're looking at her arm here, internal rotation is if you have your arm on your stomach versus external rotation, which is when your arm is out to the side. So it's actually looking at the head of your shoulder. So because if you go like this with your hands on your stomach and then bring those down to how you would propel a wheelchair, that is that internal rotation position. We also tend to see elevation of the humerus. So your humerus is your bone right here in your arm. So there's tissues that comprise the rotator cuff. So your rotator cuff is comprised of 4 to 5 muscles that kind of hold your shoulder in where it's supposed to be and allow it all of the mobility that our shoulder has. So our shoulder has a lot more mobility than almost any other joint in our body. But because of those 5 muscles, when we tend to have our shoulders in our ears, all of those muscles can get pinched in this area, and that pinching can cause pain. So the more that we can keep those shoulders down out of our ears, the thought is that hopefully we can try and decrease some of that impingement in this area, and then we can try and improve some of the pain associated with that movement. And then further stress is also caused by weight bearing during transfers and ambulation when possible. So again, kind of that pushing off from here. Even with my own shoulders, they automatically come up to my ears. So we really have to think while we're moving, which is so hard because your brain is always thinking of so many other things, right? But we really have to talk to our muscles and try and make our shoulders stay down when we're doing some of those mobilities to decrease some of that extra stress that we're putting on that joint. Okay, so we're going to go through some exercises and some rehab that we can do for pain prevention, or even to try and decrease pain if it's already present. So in the early stages of rehabilitation, we want to try and balance the training of our upper extremities to compensate for the deficits in strength due to the level of the spinal cord injury. So what does that mean? A lot of times we tend to focus heavily on big muscles when we're strength training, right? So we really want to work on these biceps and these triceps, but we ignore some of those tinier muscles that are very important for some of these things that we have to do as people with spinal cord injuries, like propelling our wheelchair, like using our arms in different forms to help us get through and complete daily tasks. So we want to balance the training of our upper extremities. So that means we want to work on not only training biceps, but we also want to train biceps and back. We want to work on triceps and chest. We want to work on shoulders by themselves, which is totally fine, or you can incorporate them in with other things. But we want to make sure that we're training all of these things and also giving those muscles breaks. So if we do biceps and back one day, the next day we're going to do triceps and chest and try and let biceps and back take a rest. So we can balance that training. We also want to monitor our BMI. So the BMI, that is what we talked about before, which is that our weight, right? For lack of a better word. It's our weight and our level of fat in our body. So we want to try to maintain a healthy lifestyle so that the overall weight of our body can decrease, and therefore we can improve the ease of our transfers and also the ease of our wheelchair propulsion. And then in regards to wheelchairs, the mechanics of wheelchair propulsion place that increased strain on our shoulders, elbows, and wrists, right? So we want to strive for optimal wheelchair qualities. So I know Moss and McGee, as well as several other places, if you don't live in the Philadelphia area, but like Kessler, there's other places as well, even Jefferson have wheelchair clinics. You can probably reach out to your PM&R doctors and kind of get referral or just a recommendation of places to go to get your wheelchair looked at. Like, do you have the correct sizing? Is it sturdy? Is it as lightweight as it can be? Are your wheels titanium? Can you use a smart drive? So that's the thing that you can connect to the back of your wheelchair that'll help you propel so that you're not putting as much strain on those shoulders. And we can work on balancing that training of our upper extremities. And then we also wanted to always be cognizant of pressure mapping. So pressure mapping is when you go and you sit on a pad, and it kind of takes a look at like your weight distribution so that they can figure out what's the best cushion for you. Is it a ROHO? Is it a gel cushion? There's so many different kinds now, but maintaining that pressure, making it flat throughout as much as humanly possible. So not all of our weight is on the left side or the right side. It's evenly dispersed is so important because that's going to make it not only easier to propel your wheelchair, but also prevent pressure ulcers, which are a huge concern in the spinal cord injury community, right? So these are all things that we want to keep in mind just as a baseline to helping maintain that shoulder integrity, helping maintain that wrist integrity, and making wheelchair propulsion as easy as humanly possible to prevent that chronic overuse of those muscles. So I am going to go through several exercises that we can work on to kind of try to either rehabilitate or further strengthen some of those muscles in our shoulders and our back. But I do just want to put this disclaimer on here. Because if you have an injury or any precautions related to arm movements or the weight that you're allowed to lift, I want to make sure that you guys consult your primary care physician or care provider prior to completing any of these exercises. So despite the fact that I am an occupational therapist, I'm not familiar with everybody's past medical history or anything like that. So I can't say that it's 100% safe for you to complete these exercises. So if you have any concerns at all, just make sure that you follow up with your doctor before you complete these. So I just want to put that in there as a disclaimer before we go through some of these exercises that you can do at home. So we're going to go through some stretches for your shoulders and arms, but also some strengthening exercises for your shoulders and arms. And like Megan said, this will be available, and I'm more than happy to email her this PowerPoint presentation as well, so you guys can use it as a reference to look back on, because don't feel like you have to take notes or anything like that. This will be made available for you guys. So one of the first stretches that we can work on is called a pectoral stretch. So your pectoral is your chest muscle. So with your elbow at shoulder height, so that's about here, 90 degrees, right? We want to place our forearm on a door jamb. So that is like the outside of a door, and make contact from the elbow to the wrist. So your entire forearm should be on the door. You're then going to lean slightly forward and you're going to feel a stretch right here. So a lot of times, because of that rounded shoulder position, your pec muscle, similar to all of those shoulder muscles, tends to get short and it does not like to stretch back out. So this is very important to make sure that you're getting this full range of motion within your shoulders. And you want to make sure to repeat that with both arms. You can also do this while seated in a wheelchair. You would just roll up to the side of the door and complete the same exact thing. Similarly, we love doors for stretches here. So a bicep stretch is going to stretch your biceps muscle, which is here, right? So instead of positioning your arm here to stretch your pec, you're going to actually straighten your arm and almost put it down at your side. Make sure that your thumb is up, because if you flip it down, then you're going to actually cause even more impingement and discomfort in your shoulder area. So make sure that thumb is pointed up, which you can see here in this picture. Then same thing, your entire forearm is going to be in contact with the door jamb, and you're going to almost slowly rotate your body away from the door jamb so that you can start to feel a stretch in your biceps muscle. And then you're going to repeat the same thing with the other side. We have a couple more stretches. So your upper trapezius is this muscle right here. So for that one, if you have the ability to mobilize both of your arms, you're going to actually sit and you're almost just pulling your head to one direction, and you should feel the stretch here. Don't crank your head because we always want to be very careful with our cervical spine. If you don't have the capacity to reach your head, you can ask somebody to help you, like your caregiver, family member, friend. Just have them go very, very gently and have them stop once you start to feel that stretch. You can also do it without your hand by just bringing your head over to the side. You just tend to get more deep when you start to use your hand to kind of give a little bit of resistance so that you can get a deeper stretch, but only if you can tolerate it. And we want to make sure that we do that on both sides as well. These trap muscles tend to be one of the biggest muscles that people use to compensate, which is why our shoulders are in our ears. So this one is super important. And then a posterior capsule stretch is actually stretching the capsule of your shoulder. So for this one, you're going to actually reach across and you can put some pressure at your elbow, and you should feel it almost like in the back of your shoulder. And then there's a picture here for that one as well. So for all of these stretches, you don't want to like really go super fast because that's going to put your muscle into shock. So we want to go slow and steady until we feel the stretch and then just hold it there. We will go through at the end of going through all of these stretches and strengthening exercises. There is a recommendation for how many days a week we should do it and for how long we should do it. So we'll go through that as well. And then we have some strengthening exercises. So a lot of these exercises are done with TheraBand. You can also do them with like a TRX band. I tend to recommend TheraBand because it's pretty cheap and you can find it on Amazon. It does not have to be the TheraBand brand per se. There are different colors. So if you have not done these exercises before, I would start with the easiest color, which tends to be yellow, and you can work your way up. Blue or black are the hardest and they have some serious resistance. So definitely do not start with those. I would start with yellow just to get the hang of some of these exercises. And as the yellow gets easy, you can kind of upgrade. So scapular retraction is the opposite of that movement we were talking about before where you have those rounded shoulders, right? So scapular retraction is pulling those shoulder blades back like there's a pencil in between your shoulder blades that you don't want to hit the floor. So you can see that in this picture right here. So for all of these exercises, you want to attach your band to a door. So they actually make pieces that you can stick in the door jamb and then close the door so that it won't fly back and hit you, because if it does, it will be very painful. So just make sure that it is very securely attached to the door that you're using and that the door is closed and not moving while you do these exercises. So you're going to face the door and hold onto the bands, and you're going to pull them back. Each time you pull them back, you want to make sure that you're really focusing on squeezing those shoulder blades together. Shoulder external rotation is again, the opposite of that exercise where you're touching your belly, right? So as you can see in this picture, she is starting touching her belly. So she's starting in this internal rotation position, and she is almost, I like to call it opening and closing a door. So you're almost using your arm like a door, and you want to make sure that you're keeping this elbow tucked in at your side so that you're really activating all of the correct muscles while doing this exercise. I sometimes have people use a towel, like roll a towel up and stick it in this and pinch it with your arm so that you don't drop it. It makes you keep your arm in that optimal position while you do these exercises. So for this one, you would do one arm and then you would switch and do the other. For the scapular retraction, you can do it with both hands, but you can also just do it with one if two is too hard, or you have one more affected extremity and one less affected extremity. And then you can do shoulder adduction. So what that is bringing the band closer to your body. So this is going to work on all of these shoulder muscles up here. I put pictures here of standing and sitting, so you can do it either way. And for this one, you're going to do one arm and then the other. So you're going to start reaching up high, and then you're going to pull that band down to your side. Try your best to keep your belly tight while you're doing it and your back, because that's going to protect your back and maintain your ability to activate those abs, so that you're almost working on your total body while you're trying to isolate the shoulder. And then we have a couple more. So your serratus anterior is a muscle that kind of hangs right here on your side. So that one helps with some of these shoulder movements. So that protraction, which is kind of the rounding of our shoulders, and retraction. So it helps with those movements. So same thing, we're going to attach that band to the door. And for this one, you can do seated or standing as well. You're going to hold the band and you're going to almost like punch forward, but keep your abs tight to protect your back and so that you don't rotate. Because if you're rotating, then you're using more of your trunk and less of your shoulder, right? So you're going to punch forward and then slowly come back. Don't let the band like slingshot your arm back. Make sure that you come back nice and slow so that we can work on these muscles that are in this area to help support our shoulders. And then shoulder extension looks very similar to that retraction where you're pulling and your shoulder blades together with the pencil. But for this one, you're going to actually pull down. So you should feel it a little bit more back here and in the back of your shoulder. You may even feel some of your triceps kicking in to help with that mobility of your shoulder. But for this one, you want to make sure that your arms stay straight the entire time and pull all the way down to your sides. And then same thing, come back nice and slow up to the top. Don't let the band slingshot you back up to the top. Coming down is equally as important as coming back up because it's training your muscles in two different directions and two different ways. Because this is a little crazy, but gravity is actually very close to 10 pounds. So even just lifting your arm up without a weight is almost the equivalent of lifting a 10-pound weight. So you want to make sure that not only are you pulling down nice and slow, but when you're coming back, you want to fight the resistance so that it doesn't slingshot you, so that you continue to work on those muscles through the whole range of motion. And then this slide just gives us some parameters for how often and when we should be doing these exercises, right? So stretching, as long as you're not really cranking into those stretch positions, can be done 7 days a week. I would recommend doing about 5 reps and holding for about 20 to 30 seconds each. If you only hold your stretch for like 5 to 10 seconds, you're not actually getting a full stretch from those muscles. You have to hold for a solid 20 to 30 seconds to get that full stretch effect and kind of get those muscles to release and go back to hopefully their original starting position, not that shortened position that they like to be in. So for each of the stretches, they're all recommended 7 days a week and 5 reps each. So that means like 1 rep is this, 20 to 30 seconds, relax, reset. Second rep, 20 to 30 seconds. And you can even go through and do all of these stretches once and then come back and do them all again 5 times. So that way your muscles really have a chance to kind of, it's called recoil, and go back to their original state before you stretch them again. For strengthening, we only want to do these exercises 3 days a week. Why is that? Because we don't want to fall back into that overuse, right? We always need to let our muscles relax as much as possible. So there have been some studies that have shown that if you do these exercises 5 to 7 days a week, you can actually increase your pain in your shoulders, elbows, wrists, fingers, because you're still overusing those muscles and causing that repetitive trauma. So we want to make sure that we're only doing them 3 days a week. My suggestion would be to not do all of these Monday, Wednesday, Friday. I would do like 2 on Monday and then 2 different ones on Tuesday and then 1 more on Wednesday and then reset and go back to the original 2 on Thursday. That way your muscles have enough time to rest and recuperate before we ask them to work again. So this is on here for you guys just as a general guide because we want to make sure that we are allowing those muscles to relax and recoil. Otherwise, we're just further causing pain by doing overuse and repetitive trauma and using those muscles that are constantly already being used for that wheelchair propulsion and those transfers. And those things are necessary for you to get through your day. So we can't eliminate them. So we want to make sure that we're using these as a supplement to try and decrease that pain and balance those overall upper extremity muscles like we talked about earlier. And then these are all of the references for all of the different information that's included here in the PowerPoint presentation. And then I also did throw in, so we do have a ton of ongoing studies at Thomas Jefferson. This one is being run by my coworker, Dana, and it looks at, you have to have a cervical level injury to be applicable and to be eligible to participate in this study. We have, I'm not super familiar with this study, but Dana would be more than happy to give you any information if it's something that you're interested in. Our second study is run by my coworker, Rachel. So for this study, it's called Coaching for Persons with Spinal Cord Injury. This one is almost like a spin-off on behavioral health. So you're assigned a coach and you work with your coach for 12 sessions. It's fully remote to try and work towards some of what your goals may be. So some of the coaching topics could be like, I have a goal on working on improved healthy habits. I have a goal of being more independent with dressing or managing my schedule or whatever it may be, and your coach can help you devise a plan to work towards some of those goals. So if you have any questions about this one, Rachel would be more than happy to answer any questions for this study. And then the last study that's on here is the study that I actively recruit for that I run at Thomas Jefferson. So for this one, we're recruiting anybody with a spinal cord injury. It does not matter your level. It does not matter if you're complete or incomplete. And you do have to come to Philadelphia for one in-person session, and then there's 2 remote sessions that you complete from your home. And this is a paid study, so you do get paid for every single session that you would participate in. We always have ongoing studies for people with spinal cord injury at Thomas Jefferson. These are only the ones that are being run right now, but in a couple months, there could be several more. So if you guys are interested in any of them, please don't hesitate to reach out, and I'd be more than happy to either answer your questions myself or connect you with the person that can. So I know that this was a lot of information, but that is the conclusion of our PowerPoint presentation. And I would love to open the floor to any questions anyone might have. There are no dumb questions, so please feel free to ask anything that pops up into your mind. And I want to thank you guys all for being here tonight. I really appreciate it.